Welcome everyone. This is the first week of the 5-week CAPER series. We hope that you enjoy the topics we have lined up and can join us for multiple weeks. Tonight, the topic is going to be acute pancreatitis. Dr. Venkata Ashkantala is also on and helped plan these sessions. We're just going to be here in the background and turn it over to our moderators and our speakers for tonight. So I will hand it over to Dr. Peter Lee and Dr. Walter Park. Peter, over to you.
Yep. Thank you, everybody, for coming. So today we're going to have two great speakers with us. The first speaker is Dr. David Jin, who is a pancreatologist and gastroenterologist at Brigham and Women's Hospital at Harvard Medical School, who's going to talk to us about management of acute pancreatitis, focusing on fluids and nutrition, and then we will have Dr. Papachristou follow that up. And then we'll leave the Q&A session until both speakers have spoken. Thank you. I'll turn it over to Dr. Jin.
All right. Thank you, Peter. Thank you, everyone, especially the whole CAPER crew for organizing this academy. It's always very fun to be in the audience. And today I've been tasked to speak on the management of acute pancreatitis, specifically fluid resuscitation and nutrition. So these are two pretty important topics. So let's kick it off with fluids. But before I do that, I'll mention, when I was in training, and I would probably guess for most of you, we were always taught that we need to fluid resuscitate, and also keep these patients in BO. So we could rest their bowels. And as we've come to understand over the past decade or so, we've probably been overwatering and underfeeding these patients. So this is a theme that's going to come up later in the talk today. So what do we know about fluids? Well, it's still the mainstay of treatment for acute pancreatitis. There are still no effective pharmacologic therapies for pancreatitis. We know that acute pancreatitis leads to hypovolemia secondary to third space losses that can contribute to a microcirculatory defect. And we also understand through observational studies that untreated pancreatic hypoperfusion is associated with pancreatic necrosis as well as mortality. But of course, there's an infinite ways to give a patient fluids. When do you start the fluids? Which fluid type? What rate? How much in terms of total volume? These are all questions that needed to be answered and have been answered to some degree. So let's first talk about when we should give fluids. Well, if you're going to give IV fluids, earlier is probably better than deferring fluids to later on the hospital course. So this is mainly based off of retrospective observational data, presenting one study performed by Wandorf and others out of Tim Gardner's group at Dartmouth. This is a retrospective cohort study of over 400 patients, and they were subdivided into patients who received early IV fluids, defined as receiving greater than a third of their total 72-hour volume within the first 24 hours. And the rest were defined as receiving late IV fluids. And you see here, those receiving early IV fluids had significant reductions in SIRS at 24, 48, and 72 hours. There was a reduction in rates of organ failure at 72 hours, as well as the need for the intensive care unit. So the second question is, well, if you're going to give fluids early, what type of fluids should you give? And I think most of us would agree that lactated ringers is the preferred type of fluid versus normal saline. This was the first RCT that looked at this, performed by Beach and Wu here at the Brigham. It was a small RCT with 40 patients. It's an open label 2x2 study. And one of the arms, he compared ringers lactate versus normal saline. And the primary outcome here was a reduction in baseline SIRS or a reduction in CRP at the 24-hour mark. And you'll see in the data here that there was a significant reduction in both at 24 hours in the group that received lactated ringers. Now, this was a small RCT, right? 40 patients total. This was open label. There was no blinding involved. So the 2018 AGA guidelines couldn't make any recommendation whether lactated ringers or normal saline should be used based off of this one RCT. But since those guidelines came out, there have been 3 more RCTs that have looked into this question. And there's also been a systematic review of meta-analysis, which came out in 2021 out of James Buxbaum's group. And they found that lactated ringers was significantly associated with reduced need for intensive care unit, as well as a reduction in overall length of stay by approximately 0.77 days. So I would say it's pretty good evidence at this point that we should be using lactated ringers. It's a balanced solution, fairly neutral pH, and likely has some anti-inflammatory properties. So if we're going to give fluids and we're going to use lactated ringers, well, how do we give it? That's the biggest question. Should we bolus? Should we put them on a maintenance drip? Should we have some goal-directed fluid therapy, or should we just give them fluids and come back a few days later and see how they're doing? Well, the 2018 AGA technical review and guidelines did look at this question. They reviewed 4 randomized controlled trials, which did use some degree of goal-directed fluid resuscitation in their study design. And you'll notice that despite there being no significant difference in any of these measurable outcomes, and despite these 4 trials having low quality of evidence, mostly because the sample sizes were fairly small, the confidence intervals were fairly big, the primary outcomes were not always the best primary outcomes. For example, Beach and Wu's primary outcome was reduction in SIRS or CRP at 24 hours, which at the end of the day, that's a proxy outcome at best for what we really care about, which is persistent organ failure and mortality. But so despite the overall low quality evidence, the AGA did suggest a goal-directed therapy approach for fluid management based off of very low quality evidence. But since then, as you all know, Enrique de Madeira and others published the results of the Waterfall trial. This was a multi-center randomized controlled trial done out of Spain primarily, and they recruited patients with mild acute pancreatitis into 2 fluid resuscitation protocols. One was aggressive IV fluids, the other half was moderate IV fluids. And this was a very important study, and it was a very well-designed study for a multitude of reasons. The first is they chose the clinically relevant primary outcome. It wasn't 24-hour SIRS, it wasn't CRP, it wasn't sepsis, which was one of the outcomes of the other RCTs. It was the development of moderate or severe acute pancreatitis. I mean, this is ultimately what we care about, because we know that, especially in severe acute pancreatitis, it's persistent organ failure which drives mortality. They also had a well-defined safety outcome, which was easily reproducible as volume overload. And they also had goal-directed checkpoints, which were well-defined. So this was the methods, the structure of the RCT. They had 1-to-1 randomization to an aggressive fluid resuscitation group. These patients were initially bolus 20 cc's per kilo, and then started on maintenance infusion, 3 cc's per kilo per hour. The other half of patients received moderate IV fluids, essentially half of that. So maintenance of 1.5 cc per hour, preceded by a bolus of 10 cc's per kilo only if the patient was hypovolemic. There was a safety checkpoint at 3 hours, and then there were goal-directed therapy checkpoints at 12, 24, 48, and 72 hours. So what did they find? Well, first off, the aggressive fluid resuscitation cohort received significantly more IV fluids, about 2.5 liters more than the moderate IV fluid group. And then this patient, as you know, was terminated early because it reached a safety endpoint before it reached any significance in the primary outcome. So they stopped recruiting after 249 because there was significantly higher rates of fluid overload in the aggressive fluid resuscitation cohort versus the moderate group. But you'll notice that it wasn't just more fluid overload. The patients who received moderate IV fluids actually had, a sizable trend towards less severity in terms of moderate or severe acute pancreatitis, and also a trend towards less necrosis. So the take-home points here when it comes to fluids is, number one, if you're going to give IV fluids, give it up front. Number two, if you're going to give IV fluids and you have lactated ringers, that's preferred compared to normal saline. And then number three, I think for the vast majority of patients who are going to come in with mild acute pancreatitis, remember that's 80% of patients, moderate goal-directed fluids is the appropriate standard of care. They should be bolused if they're hypovolemic with 10 cc's per kilo. They should be started on a maintenance infusion of 1.5 cc's per kilo per hour. And then the fluids should be adjusted based off of goal-directed checkpoints. Systolic blood pressure should be targeted to be above 90, adequate urine output, appropriate hemodilution, as well as a decreasing blood urea nitrogen. This study, the waterfall study, also discontinued fluids if the patient was tolerating oral intake after 8 hours, and I think that would also be appropriate care. All right, so that's all I had to say regarding IV fluids. So I'm gonna pivot now and speak about nutrition, which is another big topic. And I'll just preface this by saying I'm not a registered dietitian, but I will try my best here. So we know that in a lot of patients with acute pancreatitis, patients lose weight. And it's been shown in observational studies that patients may lose more than 10% of their body weight after one episode. And this is multifactorial. So patients are in pain, they have nausea, they have anorexia. Acute pancreatitis is also a catabolic state, and that can lead to a negative nitrogen balance. We know from multiple studies that pancreatitis leads to gut barrier dysfunction, and that can impair nutrition absorption. In severe cases or in cases secondary to alcohol, for example, there may be some underlying exocrine pancreatic insufficiency. But one of the big reasons is iatrogenic malnutrition, right? These are clinicians who are purposefully keeping a patient MPO in order to rest their pancreas for fear of worsening severity. So what do we know in terms of nutritional therapy? Well, let me start off by referencing this paper, which I like for two reasons. This is the paper out of Stanford. You'll see Walter Park is one of the co-authors, and I like it for two reasons. One, I like the title, Severe Acute Pancreatitis in the Community, Confusion Reigns, right? So I like that, a little bit of a snarky title, but also proves my point. This was a retrospective cohort study of 78 patients who were transferred to Stanford from a community hospital with acute pancreatitis. And they found that almost 90% of these patients were not on appropriate enteral nutrition at the time of transfer. So 65% of these patients were MPO, 24% were already started on TPN, despite them only been hospitalized for 6 days prior to transfer. And by the time they were transferred, this 90% was reduced to 17% within 72 hours. So I'm gonna be referencing a couple major guidelines. First is the 2018 AGA guidelines. The second are the 2020 European ESPEN guidelines. And I'm gonna make a few relevant points here. The first is that in all patients who present with acute pancreatitis, we should be screening for nutritional risk because they do come in anorexic, and 60% of them may have gut barrier dysfunction. So these are patients, even in mild to moderate cases, who are at risk for nutritional deficiencies. And that's especially true if they come in malnourished or alcoholism is one of their risk factors. And you can screen these patients using a pretty simple tool, the NRS 2002 tool. And ESPEN guidelines also say that all predicted severe acute pancreatitis should be considered at nutritional risk. So any severe cases or anyone who screens positive for being at risk, these are patients who we should be involving our dietitians early on. The second take-home point is that early feeding, early oral feeding is superior to delayed feeding. And this was a strong recommendation by AGA. It was also a strong consensus recommendation by ESPEN. Oral feeding should be offered as soon as clinically appropriate, essentially when the patient is ready to eat. And this was, here I have the results of the technical review from the AGA guidelines. They looked at 6 different RCTs comparing delayed feeding versus oral feeding. There's essentially no difference between the two. It's certainly not worse to feed a patient earlier when it comes to mortality, organ failure, necrosis, or infected necrosis. But you also notice in the subgroup analysis, there's actually a higher odds of requiring an intervention for necrosis, i.e. Drainage, debridement, in those patients who receive delayed feeding versus oral feeding. So based off of this, both AGA and ESPEN issued strong recommendations that we should be feeding patients of any severity as early as they're able to tolerate, and that includes within the first 24 hours. Well, what diet should you use? You don't need to start them on clears, then ramp them up to fulls, and then advance them to softs, and then to a normal diet. You can start patients immediately on a low-fat, soft oral diet. And there have been multiple RCTs and meta-analyses that have looked at this. And these have found that immediate feeding with a soft diet is equally well tolerated compared to a clear liquid diet. Advancement is not necessary. But keep in mind, there will be a sizable cohort of patients, about 16%, who will be intolerant of oral feeding. These are patients who have local fluid collections, maybe some delayed gastric emptying, some ileus, or those with severe disease. If they can't feed by mouth, then enteral feeding is clearly superior to parenteral feeding. This is another strong recommendation from both AGA and the European guidelines. Here are the results of a meta-analysis of 12 RCTs, which have compared enteral versus parenteral feeding. And the AGA found there was significant reduction in odds of infected necrosis and multi-organ failure and single organ failure in the group who received enteral feeding compared to the group who went straight to parenteral feeding. The idea is that oral feeding or enteral feeding is gut rousing, right? It helps protect the gut mucosal barrier, perhaps decreases bacterial translocation, and that's why there's decreased rates of infected necrosis. So if they can't eat by mouth, then start them on enteral feeding. What about timing and type of enteral nutrition? ESPEN recommended starting early, so within 24 to 72 hours if they're unable to eat by mouth. There have been multiple meta-analyses that have found early enteral feeding to be safe, well-tolerated, and potentially associated with reduced mortality in one of the RCTs compared to delayed enteral nutrition. And in terms of type of enteral nutrition, a standard polymeric formula is fine compared to semi-elemental formulas. Standard polymeric formula is safe and also well-tolerated. So what about the routes of enteral nutrition? NG tube feeding versus Dobhoff feeding. You know, when I was a resident, we'd always try sometimes for days to float a Dobhoff tube post-pyloric. The idea was, you know, the more distal you could get the tube, the more of those neuroendocrine cells you can bypass that are secreting cholecystokinin and secretin, the more you're resting the pancreas. Well, it turns out it probably doesn't make any lick of difference here. So there have been 3 RCTs that have looked at this specifically, NJ versus NG feeding in acute pancreatitis. And there's no difference between the two when it comes to all the relevant outcomes that I have listed here. So the AGA suggests, based off of low quality evidence, to just pick one, NG tube or Dophoff tube. The European guidelines actually recommend starting with an NG tube because it's easier and cheaper, but a Dophoff could be used in cases of digestive intolerance, or if they just can't tolerate having an NG tube in place. So who should get parenteral nutrition? Well, it should really be reserved for those who are unable to tolerate enteral nutrition, or if it's contraindicated. In other words, patients who have a complete bowel obstruction, if they have abdominal compartment syndrome with high intra-abdominal pressures, those with prolonged ileus or mesenteric ischemia. I'd say this is, the very small minority of patients will have contraindications to parenteral nutrition, but there will be patients who just cannot tolerate enteral nutrition for one reason or another. I'm of the mindset that, after 5 or 7 days, if they cannot receive adequate caloric intake via enteral route, then these patients should be started on TPN. It's always very difficult for a surgeon, after days and days and weeks of someone who has pancreatic necrosis to take a patient potentially for, retroperitoneal debridement if their albumin is 2, because we've been starving them for 3 weeks. So there is definitely a role of TPN, but tri-oral feeding certainly, and enteral feeding before that. And then a couple of topics just to round it out. Is there a role of antioxidants in severe acute pancreatitis? So there's been some studies that have looked at parenteral glutamine supplementation in severe AP. So glutamine is the most abundant intracellular amino acid. It's the preferred fuel for rapidly dividing cells, and the demand increases in catabolic states. There have been some meta-analyses that have demonstrated reduced infection rate and mortality with glutamine-enriched parenteral nutrition. But these analyses are at risk of high bias due to small sample sizes and heterogeneous patients in most of the studies. So ESPN did recommend glutamine supplementation in patients receiving TPN. I'll say the American guidelines, Aspen, does not endorse glutamine in general for critically ill patients. And then finally, is there a role for probiotics in severe acute pancreatitis? The hypothesis being that it might decrease gut translocation of bacteria. This is generally not recommended. There have been multiple RCTs that have not shown any benefit when it comes to infection rate, surgical rate, length of stay, or mortality. And one RCT actually showed a higher mortality in the probiotic group. So this is generally avoided. All right, so when it comes to nutrition and acute pancreatitis, here are my take-home points. The first is avoid routine NPO orders. The second is to feed a patient whenever they're hungry. And you can start with a low-fat, solid diet. If they're unable to feed orally, then enteral nutrition via NG or NJ is appropriate. And if they truly cannot tolerate enteral feeding, then TPN should be used. And you can add glutamine if it's available. This over here is just sort of a flow chart of how you should deliver nutritional support. This is taken from the ESPN guidelines. So with that, I want to thank you for your attention, and I guess we'll wait until the end to take any questions.
Thank you very much, Dr. Jin, for the wonderful overview. Very concise and very relevant. We're going to move on to our next speaker. That's Dr. Georges Papachristou. He's a professor of medicine, endowed chair in gastroenterology here at Ohio State University Medical Center. And he is going to talk to us about management of acute pancreatitis complications. Dr. Papachristou.
Thank you, Peter. Can you guys hear me well and see my slides?
Yeah, we can see your slide and hear you.
Great. So we're now going to move into the later phases of pancreatitis. David very nicely covered the IV fluids and the nutritional part. And we're going to be focusing more on other type of complications. much or most of the morbidity that comes out in the later stages of pancreatitis originates either from large symptomatic necrotic fluid collections and or infection of those collections, but also bleeding complications. Let's talk a little bit about pancreatic necrosis. This is a very important clinical outcome in acute pancreatitis. As you likely remember, even the revised Atlanta classifications, patients with pancreatic necrosis are classified as having moderately severe acute pancreatitis. This is a relatively common complications. Yeah, we see pancreatic necrosis in around 10 to 20% of patients that are managed in tertiary medical centers. Probably the number of or the rate of pancreatic necrosis in community hospital is lower. And then of those with pancreatic necrosis, 20 to 30%, so around 1 in 4.
George, you're actually on the speaker mode. Maybe you should change to a presenter mode.
Okay. If how could I do that? Display settings, swap. Is this better?
Yes, that looks good.
Better.
Great, thank you. So again, around 10 to 20% in tertiary centers will be managed with pancreatic necrosis, and then of those, a quarter will develop infected necrosis. Usually infection occurs in approximately 2 to 5 weeks after the development of necrosis, and usually these patients will have an acute change in their clinical status. They're going to develop either a new fever or worsening abdominal pain, nausea, vomiting, and many times we're also going to see that the collection is growing in size. And as you can see in those 3 images, the first one is a normal pancreas with the pancreatic parenchyma enhancing throughout its length with IV contrast. You can also see in this CT scan that there are some radiopaque gallbladder stones, and there is a nice simple cyst in the left kidney. This cyst is not related to the pancreas. And then you can see here an acute pancreatic necrosis with an acute necrotic collection that has, as you can see, almost replaced the whole pancreas. And this collection is still immature. You can see that it's heterogeneous with some hyperdense contents within it that likely represent debris, necrotic debris. And also you can see that there is likely a nasoenteric tube already placed. And this is what we call the Waldorf necrosis, where now the collection has matured and there is a capsule or a wall surrounding the collection. Usually those collections become much rounder as they mature. And also you can see here again, this is not a simple pseudocyst. The contents of the collection are very heterogeneous. Important to remember that when we talk about late deaths in acute pancreatitis, meaning more than 2 or 3 weeks out from the onset of the disease, most of them are driven from septic complications of infected pancreatic necrosis. How are we treating those patients? And we're very privileged to live in an area where we had great studies over the last, I would say, 15 years or so. Most of these studies are randomized, controlled trial, well-designed with large numbers, and most of them have been done by the Dutch pancreatitis study group, starting with the first study called PANTER, which compared step-up approach versus open necrosectomy for necrotizing pancreatitis, and both those approaches were surgical. This was published in 2010, and shortly after the Penguin trial in 2012, and then the Tension trial in 2018, where actually, rather than comparing a step up versus an open necrosectomy, endoscopy versus surgical step up approach was compared. And this was a very important trial and confirmed what many of us have seen in clinical practice. Granted, both approaches, endoscopic step up versus minimal invasive surgery step up, are both equally effective. In this trial that performed by the Dutch Pancreatitis group, as you can see, the primary endpoint was very common in both groups. More than 40% have major adverse events, but where endoscopy clearly did better than surgical step-up approach was the formation of pancreatic fistula with an incidence of 5 versus 32%, which was statistically significant, but also the length of stay with 53 versus 69 days in favor of endoscopy. And based on this study, which was a very well run study, now we can say in most tertiary centers that have this expertise, endoscopy is actually the preferred way to address those patients. When we talk about drainage and debridement of necrotic collections, it can be done endoscopically. Nowadays, we do it with EUS guidance. As you can see here on the top image, either through the stomach or the duodenum, depending on the position and the location of the necrotic collection. And what we tend to use these days is the lumen-opposing stents, in contrast to the earlier days where we used to do those procedures by placing plastic double pigtails. The lumen-opposing stents have many advantages, one of them being that they're very easy to deploy. You don't have to place a wire first, exchange the needle to a balloon, try to go through the gastric wall with a balloon that many times you could not, exchange the balloon to either a fistulotome or a needle knife, try to burn into the collection, exchange the needle knife back to the balloon, and so on and so forth. The lumen-opposing stents are very easy. You have a cautery catheter that we can easily go through the gastric wall into the collection, and then within a minute, we can immediately deploy the stents. Most of the times, we don't even use a guide wire to do that. And the other advantage of the lumen-opposing stents, as far as convenience, is that then you have already a tract to continue with direct endoscopic necrosectomy if needed. Other options is percutaneous drains that are placed by IR. This is the first step on the surgical approach, or surgical debridement. Clearly, this has to be minimally invasive in this in nowadays, and clearly we have to avoid open necrosectomy that has a high morbidity, as confirmed with the Panther trial. The minimally invasive surgical approach can be done following a retroperitoneal approach through VATS, or following a laparoscopic or even robotic approach with a laparoscopic cyst gastrostomy. So based on all this data, the AGA clinical practice update that actually David also referred to and was published a few years ago in 2020, the trials that we have now, the strong evidence suggests that an endoscopic step-up paradigm is the evolving first-line approach to treating patients with infected, but I will also add symptomatic pancreatic necrosis. And again, I don't want to take a lot of your time with that, but always including a video of, a cyst gastrostomy with lumen-opposing metal stents is cool. So as you can see here, we have on our EUS image a large necrotic collection. This is a necrotic collection because you can see a lot of debris. We already used the catheter and we entered the collection, and now we're deploying the first flange into the collection So we're almost halfway there with our lumen opposing stents. We're pulling the flange a little bit in, and then we're deploying the second flange into the stomach, and you can see a large amount of dark fluid already draining. This was a pretty big collection that we wanted to follow a dual approach. So from the duodenum, we placed actually a second lumen opposing metal stent during the same session, again, entering the collection through the duodenal wall, deploying the first flange into the collection, pulling the flange back to give it a little bit of tension and almost develop a football shape for the flange, and then switching many times into endoscopic view, tip away, deploy the second flange, and then actually you can see how the second flange opens. You can see the big bulge in the duodenal wall, and once we open immediately, drainage of large amount of Coca-Cola-like fluid with a lot of debris. Again, very rewarding and easier to do procedures these days. Moving from pancreatic necrosis, symptomatic infected necrosis and their treatment into bleeding complications, they are common. As you can see, pseudoaneurysms occur up to 10% based on two relatively recent reviews published between 2020 and 2022, up to 10% of all patients with acute pancreatitis. The median time to diagnose pseudoaneurysms is around 60 days, so 2 months out from AP onset. And there are some clear risk factors for the development of pseudoaneurysms. And just to give you an idea, a pseudoaneurysm, as you can see in this diagram, is a bulge within the wall of an artery. As you very well know, the arterial wall includes a lot of muscle and is a pretty strong wall, in contrast to the pseudoaneurysm that has a very much thinner wall, and that makes it much more prone into bursting and bleeding. So risk factors for the development of pseudoaneurysms include persistent organ failure, extensive pancreatic necrosis, and the use of large bore percutaneous catheters, usually more than 20 French, for drainage. How do we treat pseudoaneurysm? First of all, if we diagnose them, even if they don't bleed or we don't have any evidence of bleeding, we still have to treat them because they are these patients are at high risk for massive bleeding. And those reports reveal that colembolization was the treatment for more than 50% of those cases. And I think it's the first line of treatment currently in the US. Less frequently, and I wouldn't recommend that, is conservative management. And again, surgery can be a heroic approach, but clearly has a very high morbidity and mortality. But overall, as we said, if those pseudoaneurysms burst, then these patients have poor prognosis. Into those two case series, the mortality ranged significantly between the two, from 14 in the one in 2020 to 67 in the other one. And again, the most common locations of pseudoaneurysms are the splenic artery, as you can see it here in 36% of the cases, with the GDA, the gastroduodenal artery, second in around a quarter of the cases. Moving from necrosis, pancreatic necrosis and bleeding complications into later sequelae of acute pancreatitis. As you can see in this diagram, we can start with a single or an index acute pancreatitis attack. Some of the patients will develop recurrent attacks and will progress into chronic pancreatitis. But also, even after just a single acute pancreatitis attack, we might have a subgroup of patients that will develop diabetes, extracorporeal pancreatic insufficiency, poor quality of life, and there is some association with pancreas cancer as well. Let us be a little bit more specific. What is the progression from index acute pancreatitis to recurrent and chronic pancreatitis? Based on our large epidemiologic data, approximately 1 in 5 patients with acute pancreatitis will progress to recurrent attacks. So it's not that uncommon. In addition to that, from those that will progress to recurrent acute pancreatitis, 1/3 of them will move on into chronic pancreatitis. Now, in patients that only have a single prior AP episode, still, we might see some chronic pancreatitis, but the prevalence is much lower to around 10%. So again, this is a progression from index acute pancreatitis to recurrent acute pancreatitis and then to chronic pancreatitis. What are risks that are out there that predispose to recurrent acute pancreatitis that we could potentially modify and prevent or delay the natural history of the disease? Alcohol drinking with alcohol cessation, tobacco smoking with abstinence, gallstone etiology with cholecystectomy, but also when there are metabolic factors involved, controlling hypertriglyceridemia, hypercalcemia, and the blood glucose levels as well. Moving more specifically to EPI or exocrine pancreatic insufficiency, based on systemic reviews and meta-analysis, around half of patients will develop EPI at the time of the index admission. Then, around 1/3 of patients will continue to have EPI in follow-up. And again, EPI is more common after severe and necrotizing acute pancreatitis. However, it is not restricted to patients with necrosis. Half of patients with mild acute pancreatitis will have EPI during their index admission, and then 1/5 of them during follow-up. And as you can see in this diagram, where blue is mild and red is severe, granted, the prevalence of EPI is higher in the severe group, reaching around 35% after a year of follow-up. It's lower in the mild group, around 17% at the 1-year follow-up. However, it's not zero. So clearly, EPI is not a phenomenon, a sequelae of only severe disease, but it happens also with mild disease. Thus, it's not only related with loss of part of the pancreatic parenchyma. The mechanisms surrounding the development of EPI are more complex than that. Again, of course, doing meta-analysis, there are a lot of limitations. The studies were heterogeneous. Most of them had small sample size. There were variable methods of assessing EPI, different follow-up time points. So it was very hard to get good and if you wish, clean-cut data. That's why several years ago, I think we started back in 2017, we developed the PAPI study, which was a prospective cohort observational study, enrolling patients in 3 different academic institutions with a goal to estimate the 3 and 12-month prevalence rate of EPI after acute pancreatitis. And based on our preliminary results, we see that EPI 12 months is present in around 40% of patients. And also our goal is also to define risk and protective factors and to evaluate the impact of EPI on nutritional status and quality of life. The study is now completed. We're in the phase of analysis, and we had 90 patients completing a 12-month follow-up, and the EPI is assessed with fecal elastase 1. Moving from EPI to the quality of life, again, this is a study that we did back in when I was at UPMC, where we had a prospective cohort of AP patients, approximately 90 patients that responded to a 1-year quality of life assessment questionnaire using SF-12. And then we used a control group of the double amount, 182 age and sex max control. And as we can see from those bars here, especially for the physical quality of life, the physical quality of life is impaired in patients with acute pancreatitis compared to NAPS controls. Moving along with diabetes after acute pancreatitis, again, a systematic review involved a lot of studies, prospective studies, with all the limitations of a review like that. And as you can see, the incidence of diabetes was around 15% at year 1 follow-up and tend to increase over time to 20% between years 1 and 5 and around 40% on year 5. And again, the clear mechanism of post-AP diabetes are unknown. It's not all due to necrosis, clearly. And we just analyzed our PAPI data based on hemoglobin A1C, and we saw that the incidence of diabetes was around 10% at year 1, but very interestingly, hyperglycemia, meaning both pre-diabetes and diabetes, was around 18% at year 1. Okay, we still need more data. We still need good studies, studies that won't be based on meta-analysis. And we have to thank NIDDK for a very important initiative for a UO1 funded consortium of 10 and actually with ancillary 13 sites that started in 2020, and it's called T1DAPC. Studying the prevalence of mechanisms of acute pancreatitis after diabetes. We're now in the enrolling phase. We just started year 4 of this very important consortium. Of course, we don't have any data to share with you, but that's going to be a fantastic both prospective data set, but also biorepository for future important studies, both on the prevalence and mechanisms of long-term sequelae in acute pancreatitis. And I think that was my last slide.
Thank you very much, Dr. Papachristou. I think we have a few questions in the chat. I can go
Peter,
through.
we have like 6. We should do some rapid fire because we only have about 12 more minutes left.
Okay.
So should we jump right to them? I'll go first. What is the post-acute pancreatitis? This is from Myson. What is the post-acute pancreatitis follow-up protocols that you have in place? This is for George and David at your institutions for clinical follow-up. Is it for all AP or just a complex course, and when? George?
Here at Ohio State, we don't have actually a protocol. We don't bring all AP patients back into clinic. Granted, through Dr. Lee's and other colleagues' clinics, we tend to try to see most of them now because of research also. This will be very important for our research studies. However, as you all understand, many of those patients come from a distance. Many of these patients can be transferred to our tertiary center. So we don't have an established protocol to follow everyone. However, those with pancreatic necrosis or a more complicated course, or those, of course, that they are symptomatic, we have a low threshold for both checking a hemoglobin A1C and fecal elastase 1. I would like also to, I know that the pediatric ward is much more regular, if you wish, with the follow-up. And I would like also to share with you that there was a recent gastroenterology review article by Petrov and colleagues that actually recommended follow-up for acute pancreatitis to assess for endocrine and exocrine complications.
Great. David?
Hi. Oh, we don't have a protocol either. So I agree with George. I wish we did. Outside of research protocols, we do not have a system in place where we're seeing all of these patients in follow-up.
Great. George, do you see a role for early drainage of infected pancreatic necrosis prior to formation of walled-off necrosis?
Definitely. I mean, if these patients are symptomatic, febrile, there is a clinical deterioration of the clinical status, 100%. Granted, if we are early in the course here at Ohio State, and this is also my own personal experience and preference, is to start with the percutaneous drain. Usually these patients, and then if you drain some of the pus, of the purulent drainage, they feel much better fast, and then you give them some more time to see how the collection, the necrotic collection will evolve. Remember, based on the Dutch acute pancreatitis and the Panther data, around 1/3 of those patients, they won't need any further intervention, and the percutaneous drain will be enough to address their clinical deterioration and take care of the collection.
David, how do you assess for EPI, and how often do you do it after acute pancreatitis, given the statistics that George cited?
You're asking me, how do I assess for EPI?
Yeah.
So I send off a fecal elastase, and I'll do it in pretty much all of my patients who I see, even those with mild disease courses, because, you know, as George said, it's not just the severe necrotizing alcoholic, you know, patients. There are a cohort of patients with interstitial disease that may develop EPI. Granted, their EPI probably will resolve after a course of several months, but usually when I see them in follow-up, I'll check a fecal elastase at that time, and if they're doing well clinically and they had mild disease, then I just leave it alone. What about you, George?
George, yeah, do you agree, George?
Yeah, definitely. Fecal elastase 1 will be if you wish, the laboratory test. However, in some patients, I think even clinical presentation, if they have the typical story of, you know, oily, foul-smelling stool that it's hard to flush from the toilet. I mean, it's pretty straightforward that there is severe EPI ongoing, especially if it's associated with a lot of GI symptoms and weight loss.
Great. Peter, do you want to take over the other set of questions, beginning with yours towards David?
Sure. So just wondering what your thoughts were on the role of PERT to promote oral tolerance during acute phase of acute pancreatitis. And then the next one is, when do you consider PEG-Js or PEGs for those that have protracted course of oral intolerance?
So the first question is the role of PERT in acute pancreatitis, not those who have documented EPI or chronic pancreatitis afterwards. Yeah, it's a good question. I mean, there's likely some degree of exocrine pancreatic insufficiency during the acute phase, which could contribute to weight loss. But as far as I know, there's been one RCT that has looked at pancreatic enzymes in acute pancreatitis. I think it was published like 10 years ago. And none of their primary outcomes reached statistical significance. I think they were looking at pain, weight loss, maybe subsequent EPI post-hospitalization, and they didn't find that it was necessarily helpful. So I don't give it typically during the acute phase, but certainly would screen for EPI and give it if necessary after the hospitalization. Your second question was PEG-Js. You know, I can't recall the last time we needed to place a PEG-J in a patient with acute pancreatitis. Usually their fluid collection is drained and debrided by, you know, you or George or, you know, our advanced colleagues, and they're better. Or they're so sick and they have multiloculated collections and they can't eat, they end up, you know, being on TPN and they go for surgical debridement. So I'm not aware of any studies that have specifically looked at this, but I can say anecdotally, we don't place them very often in pancreatitis patients.
Thank you. Next question is, what do you do for patients who are allergic to pork when you consider PERT therapy, and are there any alternatives?
George, you want to take that?
Good question, correct. That's a tough one. I'm not aware right now of any alternatives, and this clearly shows a big gap in our field where we really need, with industry and with the support of NIH and IDDK, into spearheading new agents for treating complications of acute pancreatitis, like pair treatments, but also agents that might be helpful early in the disease course in patients with predicted severe disease and already an impeding systemic inflammatory response, where actually we don't have any good disease-specific treatments that target the immune system, other than giving, the appropriate amount and type of IV fluids. So I politically defer the answer of this question. I mean, if anyone else in the audience has a little more insight into that, please feel free to jump in.
Thank you. Role of prophylactic cholecystectomy in idiopathic pancreatitis. George?
Single attack, more than one attacks. I think when there are more than one attacks, I would definitely, and with a good history, physical examination, imaging studies, correct, potentially in the US as well, depending on the age and other demographics and of the patient. But in a recurrent idiopathic, I am someone that would recommend definitely cholecystectomy.
I would be the opposite side of the fence to George. I would certainly defer to your experience here, but just again, anecdotally, I've had patients, the handful of patients, 3 patients who I've sent for prophylactic cholecystectomy, never improved their clinical course. So certainly I would get in the US. We know that US may find evidence of stones or sludge that is missing on abdominal ultrasounds, on MRCP, and those patients likely would benefit. But if you don't see any evidence of that and their LFTs were completely normal during these episodes, I haven't personally found they benefit from prophylactic cholecystectomy.
Back in the days, I will show you my age as well. We used to give secretin and collect bile and signing for crystal analysis, which was a very non-specific test, correct? And based on that, we will kind of guide our decision on cholecystectomy or not. Again, in many ways, this is clearly a topic with, that both sides can be followed. I think it can be more geared to a patient by patient decision. Younger patients, correct, sending out studies, especially if there's a second attack for a genetic, risk factor or predisposition, are very important. And then if something comes back in either CFTR or other important genes, then of course you have an etiology, correct? It's at this point you can label it as genetic, and that will be not a patient that I would do a cholecystectomy. But with a good history, I think with recurrent idiopathic attacks, if we have excluded everything else, it still can be considered, I think, a reasonable approach. Again, geared into, patient preferences as well, and how anxious they are to have something done about preventing future attacks.
We have a lot of other questions. Unfortunately, we're at the hour. So I think out of respect for everyone's time, we should probably wrap things up. Is that okay, Melina?
Yes, I agree. We have 4 more weeks left, so I hope everyone is able to attend in the subsequent weeks, but glad to see such a engaged and interested audience. So thank you to the speakers, the moderators, and for everyone who attended.
See ya.
Thank
Good
you,
night.
everyone.